Perfect. Excellent. Hello, hello. All right, welcome. Thank you. Thank you for joining. Good morning, afternoon, evening, depending on where you are. Today we have a very international audience with us, and welcome to NeuronUP Academy. I'm happy you guys can all be here. As last year's academy was a success, we wanted to open up our we wanted to change it up a little bit. So this year we've invited English-speaking professionals as well. So my name is Brian. I work here at NeuronUP. NeuronUP is the leading cognitive stimulation platform for professionals. NeuronUP is basically a 3-in-1 tool, which includes a content library, a patient management tool, and a therapy management tool. NeuronUP has highly customizable activities, allowing the professionals to save time in their practice. So we created NeuronUP Academy with the idea that professionals expand and share their knowledge in the field of rehabilitation and cognitive stimulation. Before I pass the baton over to our featured speaker, I'd like to share a short video with you, so all of you who aren't familiar with NeuronUP can get an idea of what we do.
Do these work situations sound familiar? Hours surfing the internet and struggling with your computer? Tons of material to sift through and organize, yet finding the same activities over and over. Doubts about which materials to use for follow-up? Do you imagine personalizing exercises so they are just right for each individual? Would you like a simpler way to monitor progress, count on the assistance of other professionals, share ideas, and stay up to date? NeuronUP, a web platform for professionals dedicated to neurorehabilitation and cognitive stimulation. Acquired brain damage, neurodegenerative diseases, normal aging, neurodevelopmental disorders, and mental illness. Numerous materials and innovative tools, classified into over 40 cognitive processes, cataloged by difficulty, age, and mode, with a multi-format application. The treatments are adapted to each person, which favors generalization and adds greater ecological validity. NeuronUP is accessible anywhere, allowing for greater proximity to patient and the ability to design sessions so that each user can work anytime, anywhere. With NeuronUP, you can communicate with other professionals and stay current. The future of neurorehabilitation is at your fingertips.
All right, very good. So anyways, if you have any questions about the platform itself, or if you'd like to try a free trial of the platform, don't hesitate to send us an email. We have a chat feature in the website, or you can write me personally, Brian, B-R-I-A-N, @neuronup.com. So enough with the housekeeping. Let's get on with the presentation. Today we are honored to welcome Dr. Sarah Raskin to NeuronUP Academy. Dr. Raskin is a professor of psychology and neuroscience at Trinity College in Hartford, Connecticut. I'm going to read a little bit here about Dr. Raskin, as she's very accomplished. I could not memorize this for the life of me. So Dr. Raskin received her BA in behavioral biology from Johns Hopkins University and her PhD in neuropsychology from the City University of New York Graduate Center. She's board certified by the American Board of Professional Psychology, Clinical Neuropsychology, and is a fellow of the American Psychological Association, Divisions 22 and 40, and the National Academy of Neuropsychology. She has published numerous articles investigating neuropsychological functions and cognitive rehabilitation for a variety of disorders, including brain injury. She co-authored the Memory for Intentions test, published by the Psychological Assessment Resources. She is the co-author of the Neuropsychological Management of Mild Traumatic Brain Injury, published by Oxford University Press, as well as the editor of the Neuroplasticity and Rehabilitation, published by Guilford Press in 2011. Recently, she was also a guest editor of a special issue of the Clinical Neuropsychologist on Prospective Memory. I could go on and on sharing with you the accomplishments of Dr. Raskin, but in order to get on with the presentation, I will direct you to the NeuronUP blog, where you'll find links and to learn more about Dr. Raskin and her career. One last thing before we continue. I'd like to let you know that this presentation will be divided into two parts. The first part will be Dr. Raskin presenting her topic. That should last about 45 to 50 minutes. And the last 10 or 15 minutes we'll leave for some Q&A. So if you have any questions at the end, please hold off to the end too, so the presentation doesn't get interrupted and we can finish on time. But at the end, we'll ask for questions. If you have them, please write them in the chat. At the end, if we run out of time and Dr. Raskin doesn't get to your questions, I will compile them from the chat room and send them on over, and we'll post her answers on the blog. Nothing else from me, so I'd like to pass this over to Dr. Sarah Raskin. Dr. Raskin, thank you.
Hi, thank you so much. I'm really happy to be here and really honored that NeuronUP invited me to come today. And please do, if you have questions, let me know and we can go through them at the end. So today I'm going to be talking about prospective memory, which is also known as the ability to remember to remember. So the idea behind prospective memory is that you form an intention and you remember to carry it out. So unlike retrospective memory, in which you remember something that happened in the past, prospective memory involves remembering to do something in the future. If you have any trouble hearing me or anything, please put it in the chat. So prospective memory can be time-based. For example, in 10 minutes, you could all raise your hand. It can also be event-based. So if you see a picture of a clock, you can clap once to show that you saw it. And it always involves an ongoing task. Because we're not always just sitting and looking at the clock waiting for time to pass when we have to get something done. We're, of course, going about the things that we do in our daily lives. So it's important when you're assessing prospective memory that you also have the participant be doing something so they're not just focused on waiting for time to pass. Prospective memory has most likely mediated by prefrontal cortex, and the area of the brain that's shown the most correlation with prospective memory function is Brodmann's area 10 in prefrontal cortex. In terms of assessing prospective memory, there are three main ways that researchers and clinicians have used to assess prospective memory. The first is laboratory-based measures, and these are used mostly in research studies and have really been pioneered by Einstein and McDaniel. The second are clinical measures, and I'll go through some of the clinical measures that are currently available. And finally, self-report measures, where the participant or a significant other fills out how their prospective memory performance is. So just to give you a description of a laboratory measure, it might include something like categorizing words as that ongoing task that you're just doing while you're waiting. So it might be saying, are two words from the same semantic category or not? Then the prospective memory task would be a less common occurrence, like, is the font in pink? These are typically event-based tasks. Remember, event-based tasks are when you have to remember to do something when you see a particular event. And they're also typically short time durations. So an example might look like this. On the computer screen would be the words minute and sapphire. And you would be asked to say, are these from the same semantic category or not? Then the next slide on the screen might be a string of letters all in yellow. This is warning you that if you see some words in yellow, don't press the 1 for same semantic category or the 2 for different semantic category, but in this case, press the 3 for prospective memory item. And then the next slide is cat dog in yellow. So you would press the 3, and that would be your prospective memory item. There are a number of really good self-report measures. The first was by Hannon, and it's called the Prospective Memory Questionnaire. There's also the Prospective and Retrospective Memory Questionnaire, which has been used quite widely. And the one that I use the most is the Comprehensive Assessment of Prospective Memory, which I'll give you a little bit more detail on in just a second. But just to let you know that typically, while these are really important for getting a feeling for the person's own experience of their prospective memory, they typically don't have a really good relationship with objective measures. So the CAPM, or the Comprehensive Assessment of Prospective Memory, has 2 forms. You can have the individual do a self-report, or you can have an observer, either an aide or a family member or someone else, report on how they're doing. And it allows you to separate between basic activities of daily living and instrumental activities of daily living, and also allows you to rate on a 5-point Likert scale how frequent the error is. So not just do they have this error or not, but how frequently does it occur. In terms of clinical assessments, there are quite a few that have been used in research studies, but don't yet have normative data. The most widely used is probably the virtual week. It's a board game. It's an actual board game. It looks like this. You roll the dice by clicking there. So it was originally an actual board game, but now it's computerized. So you click the dice there and you start here, and whatever number you get on the dice, you move that number of squares. And you can get event cards that tell you to do something as you go through your day. And when you roll the dice and get to that spot, you have to remember to do that item. And it's shown really good sensitivity to different brain disorders. And this is created by Peter Rendell. There's also the Royal Prince Alfred, which is very brief, which is great, and is also free for anybody to use. But again, it just hasn't been standardized yet. The Miami Prospective Memory Test is part of the Canadian Longitudinal Study on Aging, and I don't think that it's been published separately by itself. There are 2 clinical measures that do have good normative databases. One is the CAM prompt, which you can see here. Did everybody clap for the clock? It has 3 event-based and 3 time-based items. Takes about half an hour. The Memory for Intentions test, which you can see here, has 4 event-based and 4 time-based. Also takes about half an hour, and both of them have really good psychometric properties. I'm going to talk in more detail now about the MIST, because it's the measure that I use in most of the studies that I do. So the MIST has 2 different time delays, a short delay and a long delay, 2 different cue types, an event and a time cue, 2 different response types, action responses or verbal responses, and the ongoing task is a word search. And I'm going to go into detail on each of these things now. So in terms of the time delay, as I said, it's 2 minutes or 15 minutes. An event-based cue might be something like, if I give you a paper that says request for records on the top, that's your cue. Or it might be time-based, in exactly 2 minutes. So that would be using the clock and basing it on time. And then there are 2 possible response types. So if I give you something that says request for records, write down the name of your doctor. And since you're writing, we consider that an action response. In exactly 2 minutes, remind me to tell you when your next appointment is. And because this is verbal, because this is you telling me, we consider that a verbal response. And so then we can compare action to verbal. And as I said, the ongoing task is a word search puzzle, and it just looks something like this. Is everyone with me? Are you all following along okay? Great, good. It also has recognition trials. And so we might say, for example, at any point during this test, Were you supposed to? And then we'll give you a series of 3 options, and we ask the participant to say which one it was. So it's recognition rather than recall. And finally, we have a 24-hour probe. So we say, please call me tomorrow at 5 p.m. or whatever time it is right now, and tell me how many hours you slept tonight. And of course, we don't really care how many hours they slept. We want to know if they can remember to do it in 24 hours using a voicemail that has a timestamp, so we know exactly when they called. And this, by the way, has proven to be the most sensitive item on the entire MIST in terms of diagnosing people with difficulties. We can also look at different error types on the MIST, and we consider a prospective memory failure to be no response. So this is when somebody just doesn't behave as if they even know there was something they were supposed to do. They just give no response whatsoever. But of course, there are other kinds of errors that people can make, like a task substitution, a loss of time, doing it at the wrong time, a loss of content, doing the wrong item. So you can score each of those error types. It has good psychometric properties, both in terms of validity and reliability. For validity, we compared it to the Rivermead behavioral memory test, because that was the only thing we had at the time that had any prospective memory items. There are 4 alternate forms, which makes it really useful for rehabilitation studies. And for this audience, I want to make sure that you all know that it has been translated into about 10 languages, one of which is Spanish, and we're just now completing a large normative data set on Spanish-speaking population, so that we'll be able to give some good standardization measures for the Spanish MIST. We also actually had just completing a short form of the MIST. We know that 30 minutes is a long time, and so we have a shortened version that looks like it's pretty sensitive, that only takes about 15 minutes, which is still a long time. But the problem is, for prospective memory, you have to wait for time to pass. So it's hard to make an item any shorter than that. The MIST also can allow you to do a little bit of a process analysis. So by looking at the kinds of errors and the kinds of correct responses that the person made, you can think about things like, was it an encoding error versus a storage error versus a retrieval error, the same way that you might do for retrospective items. Now, I mentioned previously that self-report measures don't seem to correlate well with objective measures. And we just did a study published in 2017, you can see here, where we actually compared an Einstein laboratory measure to the MIST and then the CAPM self-report measure within the same group of individuals who were healthy adults, as well as some with traumatic brain injury. And we again found that the self-report measure did not correlate with either of the other 2 measures. However, they did correlate with each other. So correct items on the laboratory measure correlated with every item on the MIST. Event cues correlated with false positive and correct on the laboratory measure, which makes sense, right? Because the laboratory measure is an event-based task. And then total errors on the MIST correlated with errors on the laboratory task. So I think this gives us a good sense that the MIST as a clinical measure measures some of the same things as a laboratory measure, but not all the same things, especially, if the laboratory measure is only event-based. So to me, this suggests that when you're working with a participant who may have a prospective memory deficit, it's important to look at these 3 different measures and think about how you may be measuring different aspects of prospective memory with each of these measures. And again, I always think giving a self-report measure is important, just to understand what the experience of the person is who has the prospective memory deficit. As Brian mentioned, we just published a special issue on prospective memory in clinical populations. This was in the Clinical Neuropsychologist, Volume 32, Issue 5, which you all are welcome to look at. There were review articles written by different authors on each of the conditions listed here, as well as these 4 original research articles. And just to summarize a little bit of what was found throughout these populations, in terms of type of cue, most consistently, almost everybody finds time-based cues to be more difficult than event-based cues. And this isn't surprising because time-based cues are more difficult. If you think about it for yourself, remembering to do something at 2 o'clock, call your mom at 2 o'clock, is more difficult than remembering to call your mom when an alarm goes off, which is why many of us set alarms in our phones and things. And so that was true for each of these disorders. Time-based cues were harder than event-based cues and require more cognitive control. In this one study, they did report time-based cues were better than event-based cues, but the authors felt that this might be an artifact of the kind of items they were giving. They weren't the same level of difficulty. And then there's been no consistent finding in the 3 articles that dealt with autism, Parkinson's, and mild cognitive impairment, in that both seemed to be equally impaired. It's also clear that prospective memory is made up of a large number of cognitive functions, including retrospective memory. So the thing that you have to remember to do, so remembering to make a phone call, the item phone call is really a retrospective recall item. So it's not surprising that in these studies they found a relationship with retrospective memory performance. It's also highly correlated with attention and, of course, with executive functioning. Not surprising, it really involves planning and future thinking and involves prefrontal cortex. In terms of type of errors, those with brain injury, schizophrenia, and Parkinson's showed no response errors. People with mild cognitive impairment showed that kind of retrospective memory, loss of task sort of error. And then those with Parkinson's showed loss of time errors, which I think is really interesting. And when I show you some data in a minute on people with Parkinson's, I think that their time perception is going to be an important thing for us to think about when we think about prospective memory in this group. So now I'm going to just go sort of briefly and quickly through a number of different disorders, just to give you a sense of the kinds of ways that prospective memory might be disturbed in these particular disorders in different ways. Everyone still good? Okay, good. All right, so in terms of healthy aging, one question that we have is, at what age does performance start to decline? Another question is, what's happening with the aging paradox? And I'll explain what that is in a second. And finally, could prospective memory be an early marker of when dementia is likely to occur in people with mild cognitive impairments? So what's the aging prospective memory paradox? Well, it turns out that in laboratory studies, people who are older perform more poorly, and that's what you would predict, right? That's what would happen. But on more naturalistic tasks, older adults are unimpaired or even superior to younger adults. And this is a question people have really struggled with. And of course, there are a lot of possible explanations. One is that laboratory tasks require greater cognitive control that might rely on better prefrontal functioning. It may be that people who are older just are more focused on getting the task right. It might be that they have less things to remember in their daily life. It might be that they really wanted to prove that they could do this task, whereas college-age students, for example, might be willing to just not bother with getting the 24-hour task done once they're out of the lab. But if it is due to reduced frontal lobe functioning, then age should be more sensitive to time-based tasks than event-based tasks. So this is what we found. We did a group of 20 to 30-year-olds, a group of 40 to 50-year-olds, and a group of 60 to 70-year-olds. And while there was a little bit of drop-off in the oldest group on event-based tasks, it wasn't a significant difference. And this is on the MIST, but you could see there is already a significant difference on time-based performance in the oldest group, which does go along with the notion that this is because of cognitive control and probably the beginning of a decline in prefrontal cortical functioning. But here's the paradox. So on the 24-hour task, which we consider to be our most naturalistic task, what you see, this is not a significant difference, but at the very least, we can say there's no decline in the oldest group on that 24-hour task. So we have within the MIST sort of reinforced this really intriguing question about the age prospective memory paradox. And then the other thing we did was we brought the oldest group back in a year later after the initial testing. And at initial testing, we had screened everybody for dementia, so nobody had dementia. And a year later, we tested them again, and we looked at the people who a year previously had been greater than 30 on the MIST versus those that had been less than 30 on the MIST, and compared them a year later on the dementia rating scale and the mini mental. And what we found was a significant difference between those groups. So this is just the beginning of kind of an interesting question about whether prospective memory may turn out to be a good early marker of somebody who's got MCI and may be about to convert to having more of a dementia. And we're following up in a larger study on this right now. I'm going to turn now to a different group, which is individuals with schizophrenia. And in this group, our concern was really does prospective memory have something to do with why people might forget to take their medications? So although frequently people with schizophrenia may be called non-compliant, or there's lots of psychodynamic reasons that people may look at for why they fail to take their medications when they start to feel better, we were curious if maybe one piece of the puzzle might be that they really just can't remember very well to take medications, that they might need some kind of supports or rehabilitation to help them do that. So we gave them the MIST, we gave them a test of medication management, which I'll describe in a second. And we also gave them a test of virtual reality task of medication management within an apartment, which I'm not going to describe in the interest of time because it didn't really pan out. So just to describe to you the medication management task, this is from Patterson. You give them a pill box and some pills. They're not real pills. They're dried beans in different colors. And you tell them a specific dosage, time of day they have to take it, and whether or not to take it with food. And then throughout the course of the test, which takes about 30 minutes, you score the number of pills taken at each time of day, the time of day the pills are taken, and the total number of pills taken. And then you get a final score in medication management. So looking at the MIST, the lighter orange bar are healthy adults, and the darker bar are people with schizophrenia. And you can see that the people with schizophrenia are impaired on all of the scales on the MIST. So they do have a poor prospective memory. And looking at the errors, the kinds of errors they made were mostly just forgetting, not even acknowledging that there was something they were supposed to do on the test. So, everybody does a few, loss of content, loss of time, but really the biggest finding and the only finding that was different from healthy adults was just as if you'd never asked them to do anything. And so this can really be problematic in terms of somebody who really needs to take medication to stay healthy. And most importantly, we did find a significant correlation between the MIST and the medication management test. So in conclusion, time-based cues correlated positively with total pills taken. We did not find a relationship with the virtual reality test, which either the MIST or the medication management. And again, I can answer questions about it at the end if people are interested, but we're working on trying to make this apartment a little bit more sensitive to prospective memory. So now I'm going to talk about Parkinson's. And as I said, in this study, we were really interested in time perception and how people with Parkinson's do in terms of whether their perception of time is the issue that gets in the way of their ability to perform prospective memory tests. So for this, we had to give them a measure of time perception. And we created this one, although there are some out there that are available. We separated this into what we considered prospective time sense versus retrospective. For the prospective one, the screen would flash, and then you would see a series of letters go by, and you would have to press the A button if you saw an A on the screen. In addition, you had to be monitoring your own internal time sense and press the space bar after either 1 minute, 5 minutes, or 10 minutes. For each trial, we gave the participant a different amount of time that they had to respond to. For the retrospective one, the screen would flash, a series of letters, press the A if you see the A, and then the screen would flash again after either 1 minute, 5 minutes, or 10 minutes, and the participant would have to say, oh, I think 1 minute went by, or I think 5 minutes went by, or 10 minutes went by. So we gave them both of these measures of time sense, this one that we think of as prospective, future forward time sense, and this is retrospective, what's your sense of time that's already passed. So here on the MIST, what we found was people with Parkinson's in the darker bar here were significantly impaired on time-based tasks, but actually were not impaired compared to healthy adults on the event-based task. They showed a unique deficit only in the time-based tasks. On the time estimation task, again, they were mostly impaired on the prospective item and only at the higher amounts of time, so 90 seconds and 120 seconds. They showed impairment, smaller amounts of time they did not. Oh, sorry. So just to conclude, we found that they were impaired in their ability to estimate time moving forward, and that this seemed to be related to their ability to remember time-based prospective memory items. So I think it's really important as we think about what prospective memory is to be thinking about variables like, does the person have a good time sense? And I'll talk at the end about rehabilitation strategies and whether actually rehabilitating time sense, time perception, might be one avenue to look at in terms of making people's prospective memory better. All right, so the next group that I want to talk about is, this is with college students. There's only been one study that I know of with adults looking at long-term alcoholics. This was college students, and we wanted to look at their drinking behavior and prospective memory. So we, in this case, couldn't use the MIST because it was part of a very large battery, and the MIST just takes too long. So instead, we did a time-based task in which we said, record the current survey question after 15 minutes of working on a survey. So you're working on a survey on a computer. As soon as you notice that 15 minutes has gone by, I want you to write down which item you're on the computer. The event-based task, we handed them a cash voucher, and we said, in order for you to get paid, you have to turn in this cash voucher when you finish the computerized task. So this was time-based, 15 minutes, and this was event-based when you finish the task. The task took most people about 15 minutes, so it was about the same amount of time. And then we grouped the students, these are university students, into non-drinkers, people who had never consumed alcohol based on self-report, light drinkers, and heavy drinkers. Heavy drinkers met the criteria for alcohol use disorder from the DSM, or drank more than 50% of the weeks in the preceding 6 months, and binge drank for more than half of the number of drinking incidents reported. And binging was defined as 4 or more drinks in a sitting for women, 5 or more drinks in a sitting for men. Okay, does everybody so far so good with that? Good. So here you have the 3 groups, the non-drinkers, the light drinkers, and the heavy drinkers. And this is just showing you what their drinking behavior was like. It's a little astonishing. So this is the number of drinks they've had in the past 30 days. This is the number of times they've binged drink in the last 30 days. Again, for men, 5 or more drinks. For women, 4 or more drinks. This is the number of blackouts they've had in the past 30 days. And I know it's a little confusing to see blackouts here for the non-drinkers, but that's because our measure of blackouts had 1 equals never. So 2 equals 1 to 2 times, 3 equals 3 to 4 times, 4 equals 5 or more times. And so you can see the heavy drinkers are actually experiencing quite a few blackouts in the last 30 days. And this is the most drinks they've had in a 24-hour period. And so you can see the non-drinkers, the light drinkers, and the heavy drinkers. And here's the performance of the groups on the the time-based task. And what you can see here is that the heavy drinkers are significantly impaired on the time-based task, but not on the event-based task. So heavy drinking seems to affect time-based prospective memory, but not event-based prospective memory. But in terms of the event-based prospective memory, it was related to blackouts. So there was a significant relationship between blackouts and event-based prospective memory. And we think this is because blackouts really selectively affect hippocampal regions rather than prefrontal regions. And event-based items require you to remember the specific content of the event. So although groups there were impairments in both groups, there were impairments based on different drinking behaviors. So now I'm going to turn to our work on traumatic brain injury, and this is also where I will introduce some of our rehabilitation studies. So we're interested in what happens to prospective memory in people who have traumatic brain injury and whether these deficits can be treated. So we want to characterize prospective memory deficits, see which treatments are effective, see whether our treatments generalize to daily life, and then see whether these gains are maintained over time. And all of this is so that you don't have to buy the to-do tattoo, which is an actual item that you can buy in the store. You put a tattoo list on your hand, and then you remember what you have to do. But obviously, this is not practical in the long term, so we want to do some rehabilitation so that we don't have to tell all of our patients to do this. For this study, these were the neuropsychological measures that we use. As you can see, they're really focused around attention, memory, and executive functioning, and then also time estimation because we're interested in that. We gave a series of generalization measures. For the highest level of generalization, we looked at the community integration questionnaire. To look at memory in general, we looked at the everyday memory questionnaire. To look at prospective memory, we used the Hannon prospective memory questionnaire. And then we used our diary study, which we use in all of our studies. And in this case, we actually sit down with the participant and say, what are 10 things that you actually have to get done in the next week? And we have them write those 10 things down, 10 things that you really have to do. And then over the course of the week, we train somebody, either an aide or a family member or a friend, to just score how well they did on those 10 items. They're scored on a 2-point scale. So 2 points, they just get it correct. 1 point, they get the correct item, but at the wrong time, or the correct time, they do the wrong item. And 0 is they don't do the item at all. And then again, we gave our medication management, that Patterson test that I explained before. So in terms of performance on the MIST, you can see, again, people with brain injury are impaired really on every scale on the MIST. So they're more impaired at longer time cues than they are at shorter time cues, and more impaired on time-based tasks than event-based tasks. And so now I'm just going to talk a little bit about cognitive rehabilitation, and then I'll show you how they did on cognitive rehabilitation items. So cognitive rehabilitation, I know many of you already are experts in cognitive rehabilitation, but it's the process of relearning skills that have been lost. And it's important for people with prospective memory because, of course, prospective memory can have some very serious consequences in daily life, including forgetting to take medications or go to doctor's appointments. So when we think about approaches to rehabilitation, we can separate them into environmental modifications, which can be things like color coding, all the things that go together, so that you remember to do those things at the same time. Leaving something like your pills out on the counter so you can't miss them. Putting Post-its on your desk, or training family or coworkers to help you. When we think about compensations, this can be planners or notebooks. It can also be electronic devices, smartphones. And then there are a couple of large packages that have been put together that you can find. One is CogSmart, Beth Twamley's group in California, And another is the ecologically oriented neurorehabilitation of memory group, which you can also find online. In terms of direct interventions, process training, which is the work of Katie Mateer, McKay Solberg, and others. Functional skills training, of course, behavioral modification, and then using pharmaceuticals. And then finally, we can think about metacognitive approaches. And this can include awareness, goal management training, Brian Levine's work, self-regulation, or mindfulness, which is shown to be really helpful. And what I would say in terms of cognitive remediation from my perspective is that I often use all of these in the same participant. Certainly, I often use both compensation and direct interventions. So I wouldn't say that you need to choose one or the other. It really depends on the individual needs of the participant. And focusing specifically on compensatory approaches like visual imagery or mnemonics, or external like using a notebook or an electronic aid. And I just want to say in terms of external devices like phones, so I know people in other countries are surprised, but most of the participants that I work with in the States do not have smartphones, and they do not have Wi-Fi in their homes. So it's really difficult to expect them to rely on that kind of monitoring device. And so for any participant, these are the kinds of things that you need to think of. Cost. Does the alerting mode work for them? Is it wearable? Is it easy to learn how to use? And does it match the kind of memory problems that they're having? I think it's also important using any of these techniques that we not what we used to call train and hope, but that we actually plan for generalization. And these are some of the ways that I think are important for you to think about in terms of planning generalization. The most important is probably from before you ever start doing any remediation to select a method for measuring how you're going to generalize. Using reinforcements from the natural environment, using sufficient examples, etc. And while I do believe compensation is important, I also think that there's reasons why it's important to do training that doesn't require compensatory devices. So if we're going to look at neurorehabilitation that actually improves brain function, we need to look to what we know about brain plasticity. And the most important thing here is that it requires repetition. So the way the brain changes is repetition. So it's hard to find quick and easy rehabilitation strategies. You really need to be doing something that the person repeats over and over. And the other important thing is that experience-dependent changes interact with each other. So you need to be thinking about all the different things going on in this person's life. So for prospective memory specifically, repetition, sufficient trial, sufficient reward engagement, and planning for rehabilitation. So the first study I'm going to show you, we compared rote repetition, visual imagery, goal management training, and elaboration of cues. Rote repetition, we just do this. So we give them a command, a time delay, an ongoing task, which is often a word search. And then we score them on a scale of 2, 1, or 0 if they're doing time-based, and 2 or 0 if they're doing event. And we just have them repeat over and over again, and making the time delay get longer and longer and longer, or making the ongoing task more and more distracting. For visual imagery, we patterned this after Grilly and Gliski's study, where we said, imagine you are performing the task. Imagine with as much detail as possible, describe to me the detail. They're given feedback and try to make a really good visual image. Goal management training is taken from Brian Levine's work. So what's my goal? Define the main task. List the steps required to complete this task. Ask yourself, do I know the steps? If not, go back. If yes, do the task. And then check, am I doing what I'm supposed to be doing? If yes, great, go on to the next goal. If no, come back to the list, list out the steps, and try it again. And then elaboration of retrieval cues is similar to visual imagery, But this time you're really focusing on what the cue is going to be. What will it look like? What will it sound like? Is it a grocery store because you have to stop for groceries? What does the grocery store look like? As much detail as you can around the cue. In terms of performance, our people with brain injury showed a significant improvement with rote repetition and visual imagery. They did not show improvement with either goal management training or with cue elaboration. In terms of the diary study, our measure of generalization, rote repetition was the only thing that showed a significant improvement in their daily life. And some reasons rote repetition might be the most helpful is repetition, a chance for testing. It's typically error-free. It gives them multiple examples, and it may increase prospective memory being more automatic. We then did a separate study just on visual imagery. And in this case, we did an ABBA crossover design. And we did show again that on the MIST, visual imagery showed improvement compared to the non-treatment control condition. Importantly, we also brought people back 1 year after follow-up. And I'm just going to draw your attention to this last series of bars. These are healthy adults 1 year later. These are people with brain injury pre-treatment, post-treatment where there was a significant improvement, and then 1 year later where they actually continued to improve. Similarly, on our generalization measure, you can see here, the yellow now is 1 year later, they continue to improve. This is without any treatment intervention from us in the intervening year. We don't know, of course, we haven't tested why this is true, but one possible reason might be that they're practicing every day in their daily lives, that we got them up to a place where they could practice every day. Now I'm going to show you a study that's ongoing right now. It's a randomized control trial. There's an active treatment group again and an active control group. The active control group is learning about the brain and about brain injury. And we're also doing fMRI in this particular study. So these are the tests that we gave, again, focused on memory, attention, executive functioning. And then we gave these measures, our diary study for daily life, as well as the comprehensive assessment of prospective memory, the World Health Organization quality of life, Beck depression, and Beck anxiety. In this case, our training was individualized. So we looked at their performance on the MIST, and we said, is there a primary problem with attention, intention retrieval, encoding, planning, or time perception? And for each of these potential deficits, we have treatment modules that go along with them. And you can see all of these on our website. I have the link here. So for attention, we do attention training or increasing cognitive load. If it's intention retrieval, we do enactment, which is asking them to act out the item before they have to remember it. And then the visual imagery. For encoding, we slowly reduce cue focality. Cue focality is how much is the item like the thing that needs to be done. So if I say, here's your request for records, write down your doctor's name, those two are very related. But if I said, here's a piece of paper, draw a flower, those things aren't necessarily related. In terms of planning, we did, again, goal management training, and then we did implementation of intentions, which is something that's been used a lot in literature on, say, smoking cessation or weight loss, where you have the person just say, I will remember to do this. And this was shown in one study to be helpful in prospective memory in healthy adults. It was shown in another study not to be helpful in brain injury, though, but we wanted to just keep trying it as an option. And if the problem is time perception, then we do time training. 10 two-hour training sessions randomly assigned to either the rehabilitation or the active control. And active generalization training using the diary task and future episodic thinking training with the diary task. and again scored on a scale of 0 to 2, 2 if they completed it, 1 if it was completed at the wrong time or the wrong item, and 0 if it wasn't completed. Here's a timeline of the study, pre-testing assessment, pre-treatment fMRI, 10 treatment sessions, post-treatment assessment, and post-treatment fMRI. At baseline, we showed a good prospective memory activation in the regions that you would expect for the prospective memory task versus the ongoing task in a lot of prefrontal regions, including BA10, and some temporal regions for the retrospective component. Looking at performance on measures of memory at baseline, pre versus post, we showed an improvement on the MIST in the active treatment group, but not the active control group. Also on the Benton visual memory task, but no difference between any of the groups on the Hopkins. In terms of our measures of generalization, we also showed significant improvement in the cognitive rehab treatment group, but not a significant improvement in the active control group. In terms of pre-treatment versus post-treatment on the fMRI, again, the N is very small, but for an fMRI study, not too bad. And we do see in the active treatment group increased activation in some of these prefrontal regions like BA10. So in conclusion, people with traumatic brain injury improved on the training task. Treatment gains were reflected on measures of generalization and maintained for a year after treatment. And then I just want to end up with telling you just a few other things for those of you that may not be doing a lot of cognitive rehabilitation yet, that we need to think about the whole person, things like people's beliefs about their own memory capacity, and this leads to issues of diagnosis threat, which we've actually shown in people in terms of their prospective memory, especially people who are aging. So if you give them the impression they're going to do poorly on a prospective memory task, they will do worse. You know, if you say this is something that older people have trouble with, they'll do worse than if you tell them that this is a task that older people don't have trouble with. And again, here's the person with brain injury, you, and the treatment. All of these are embedded within the setting. So you have to think about how the setting might be impacting the person. This is all embedded within their social world. Do they live alone? Do they have a supportive family? Are they in a place where they're isolated or a place where there's good transportation to get out and complete tasks they might want to do? And of course, this is embedded within their culture. And I've actually just completed a study on prospective memory within people who are Spanish speaking from Trinidad versus people who've been enculturated into the United States. Future directions, we might need a more fine-grained analysis of what we mean by prospective memory. So we know it's attention, memory, and executive functions, but we might want to do that in a more fine-grained way. We might want to look at different methods for some of these techniques. So for imagery, does it matter if we ask the person to imagine themselves as an observer or imagine themselves as themselves? And we might need to look at underlying mechanisms like motivation and arousal. We might need to individually tailor the treatments based on severity of the injury. McKay Solberg did a nice study that showed that you might need to tailor based on the severity of the deficits. And we might want to continue to use imaging techniques to give us a better sense of what happens in the brain when we do these treatments. And of course, just to reinforce again, that the idea behind all these treatments is generalization to daily life, so that we don't send our participants out into the world looking like this. So thank you very much. I want to thank the students that are in my lab right now, making neurons here out of pipe cleaners. And I'm very, very happy if people have the time to take any questions. You're welcome.
Thank you, Dr. Raskin, for the great presentation. And if you guys have questions, please go ahead and write them in the chat.
So I can speak. For Virtual Week, Peter Rendell is the one that has been using it. And if you would like to send me an email, I will connect you via email. And I'll type my email here so that people can see it. It's also on the first slide. So I have a question. How do you think that speed of processing impairment might affect prospective memory? Yes, I absolutely think that that's going to be a huge issue, and one that I think hasn't been looked at enough. I think along with the idea that time perception is impaired, I think those same people, what we're really seeing is a speed of processing impairment that goes along with that. And so I think that's a really, really excellent question and something that we need to think about. And I think there hasn't been enough research done on groups like individuals with dyslexia, for example, or other conditions that might be specifically impairing speed of processing. Yes, you can purchase the MIST. Again, if you want to send me an email, I can send you the information. And in fact, if anybody would like to help us collect data in Spanish on the Spanish MIST, please send me an email. I'll gladly send you the Spanish MIST, which isn't published yet. It's still just in development. And I would love to just get your thoughts, feedback, whether it works for you, whether you would change any of the items, and whether you want to collect any data and send it to me. Can Allied
Dr.
Health
Raskin?
OT administer the MIST? Yes, absolutely. The MIST is not restricted in terms of training and who can administer it. And occupational therapists certainly would be able to administer the MIST.
Dr. Raskin, this question from Jessica is the PowerPoint available for download? Is this something you would mind sharing with our viewers?
Okay. And if people have questions after we're through here today, hi, Diane, then please feel free to email me.
Dr. Raskin, can you hear me?
I'll give people a couple more minutes if anybody has any more questions. So my email again, I'll type, but it's also on the first slide. Oh, here, I'll go back to the first slide. That would be smart. So my email is here, sarah.raskin@trincall.edu.
Dr. Raskin, can you hear me? Hello? Dr. Raskin? Hi, guys. Can you guys hear me?
Okay.
Future, so if you want to revisit, or if you have any friends or colleagues that are interested in in checking it out, we could do that. Any last minute questions here? Dr. Raskin, is the Spanish version the Latin American or the Spanish version?
So it's Latin American, Puerto Rican, Latin American, yeah.
Okay. Very good. Any last minute questions?
So is the role of anxiety on prospective memory? I see a question there. So that's another really great question, and certainly any level of anxiety is going to affect people's ability to maintain their attention over time, which is a key component of prospective memory. There's been one study done on anxiety and PTSD that I'm aware of, and if you want to email me, I'm happy to send you a link to that study. Sure, absolutely. Just send me an email.
All right. Well, let's see what Yolanda has to say, and then we'll.
Okay. Thank you.
We'll give Yolanda. There we go.
Would you consider to include motivation training in your training? Yeah, I mean, I think that's a great idea. Absolutely. And we're just starting to also think about including things like mindfulness, which I think is also going to be really important.
Nick, what?
Great.
Nick, feel free to send me an email, or Dr. Raskin as well. Any questions you have regarding the presentation, or?
Yeah, so Nick, my email is right here on this slide, sarah.raskin@trincol.edu.
I'll type mine in too in case anybody needs me.
Okay. Oh, okay. So I don't, so he says he can't see the email because he's on his phone.
Dr. Raskin's email is Sarah, S-A-R-A-H, .Raskin, R-A-S-K-I-N, @Trincol, TRINCOLL.edu.
Would you consider that time-based performance might be related with subcortical activity? Yeah, I think that's absolutely a likely scenario. I think Yolanda, I think you're absolutely right, which is why I think subcortical disorders like Parkinson's, using those kinds of subcortical structures, are probably more impaired on time-based. But I also think, so I think that's the time sense part of it. But I also think that time-based activity, because it requires planning, is pulling those prefrontal regions as well. So I think it's part of that whole prefrontal, subcortical, those dopamine loops, I think is what's being activated in time-based prospective memory. Whereas I think event-based is more through those hippocampal regions. Yeah, good question about the cerebellum. I don't know. I don't know that anybody's looked at that at all yet.
All right. Yolanda's full of questions. One more.
Yes, plenty to be done. Good. Exactly. No, don't apologize. It's great. It's great. All right.
All right. Well, let's wrap this up. I'm gonna paste a couple of links in here for the upcoming academies, if you want to check them out.
Great.
And again, thank you so very much, Dr. Raskin, for this very interesting and informative presentation. And if anybody has any questions for Dr. Raskin or for NeuronUP, please don't hesitate to write either Dr. Raskin or myself. And thank you for your time, and hope to see you in the next presentation.
Thank you all. Thanks very much.
Yep.
Thank you, Brian.
Bye-bye.
Bye.